Welcome to the Deep Dive. Today we're plunging into a really significant challenge in animal agriculture, porcine edema disease, ED for short.
Mm-hmm.
Now, this isn't your run-of-the-mill infection. It's quite specific, a systemic toxemia, and it presents some unique problems.
That's right.
We got some comprehensive reviews here, and our mission is to sort of unpack this thing for you, its unique traits, its economic hit, which is broader than you might think, and the strategies now being used to fight it.
Exactly. We want to pull out the crucial bits from these sources so you understand not just what edema disease is, but, you know, why it acts the way it does, and critically, how science is tackling it now.
Right. A clear, digestible overview.
Focusing on the core mechanics and the implications, yeah.
Okay, so let's define it. What's the fundamental thing about edema disease? Because it's not what people might first assume, is it?
No, exactly. The crucial thing to grasp is that it's not primarily about diarrhea, like many gut infections. It's an acute systemic enterotoxemia, often fatal, and it hits pigs mostly in the immediate post-weaning phase, say 7 to 14 days after weaning.
And the effects are systemic.
Yes, things like that, characteristic subcutaneous edema, the swelling, plus neurological problems, and often sudden death.
And one of the weirdest things, this production paradox, is it seems to target the best pigs, right? The fastest growing ones. How did that work?
It really is counterintuitive. Basically, the very things we do to push performance, like high-protein starter diets for rapid growth, they inadvertently create the perfect gut environment for the bacteria causing ED.
Yeah.
So the pigs eating the most, the ones with the best genetics for growth, they become the most vulnerable. Our production strengths become risk factors. It's quite a twist.
That paradox is really something. So if it hits the best pigs, what does that mean financially for a producer? Paint that picture for us.
Well, the direct losses are obvious and severe. Mortality can hit 50, even up to 90% in affected groups. And since it hits the heaviest, most valuable pigs in the nursery, that's a big financial blow right there.
But it's not just the dead pigs, is it?
No, not at all. There's this insidious economic drain from subclinical forms. Pigs can be colonized, suffer low-level toxemia, but show no obvious signs.
So they just don't perform as well.
Exactly. Reduced average daily gain, slower growth rates, and studies show the bacteria, STAC, can be present in, well, up to nearly 70% of clinically healthy herds.
So it's lurking.
It is. And if you look at similar production diseases, losses from reduced gain and increased mortality can range anywhere from, say, $8 to $30 per pig marketed. So the real cost goes way beyond the pigs that die suddenly. It's an ongoing drag.
Okay, now that we understand the timeline and the impacts, let's zero in on the actual culprit. What exactly is causing this?
Right. The agent is a specific type or pathotype of Shiga toxin-producing E. coli STAC. We often call it edema disease E. coli, or EDC.
So not just any E. coli.
Okay, definitely not. It is a specific set of virulence genes. It's virotype. Common types are O138, O139, O141. And interestingly, O147 popped up as a major cause in the U.S. from the late 90s.
And its main weapon, the thing causing the systemic chaos.
That would be Shiga toxin 2E. SAES-TX2E. It's a really potent cytotoxin.
How does it work?
It has two parts, A and B subunits. The B parts latch onto specific glycolipid receptors on the pig cells. Then the A part gets inside and just shuts down protein synthesis. Irreversibly, kills the cell.
And which cells does it target?
Crucially, it targets vascular endothelial cells, the cells lining blood vessels. That's the key to the whole disease process. A precision strike, really.
So to launch that strike, the EDT needs to get established first. It needs a key to the castle, so to speak. What's that?
That key is the F18 fimbrial adhesins. Think of them as tiny grappling hooks on the bacteria's surface.
Okay.
They're essential for EDT to stick to the small intestine wall, specifically binding to F18 receptors on the pig's gut cells. Without F18, the bacteria just get washed out. They can't colonize.
You mentioned F18 variants, F18AB and F18IC, linked to ED or diarrhea. And this connects to when the disease hits, right? That specific post-weaning window.
Exactly.
Right.
There are those two main variants, F18AB more with ED, F18AC more with post-weaning diarrhea. They both use the F18 receptor, but maybe slightly differently. But the really critical thing is the host side, the pig's F18 receptors. They don't really show up in significant numbers until about 3 weeks of age.
Ah, so the timing is dictated by the pig's development.
Precisely. It's this highly specific coevolution. The bacteria need the receptor, and the receptor appears right around weaning time. That's why ED is almost exclusively a post-weaning issue.
Which makes diagnosis tricky because E. coli is normal in the gut, A simple culture won't cut it.
Absolutely not. You'd find E. coli anyway. Definitive diagnosis needs molecular tools like PCR.
Looking for what specifically?
You need to confirm the genetic fingerprint, the gene for F18 Fimbriae, that's FET-AA, and the gene for the toxin, STPX2E. You need both to say it's EDC causing edema disease.
Can anything else muddy the waters and diagnose it?
Yeah, some EDC strains have other weapons, accessory virulence factors like heat-stable enterotoxins, STO, STB, EST1,
Leading.
meaning you might get mixed signs. Neurological problems plus diarrhea, which can confuse things in the field. Oh, and most EDC strains are alpha hemolytic on blood agar plates in the lab. That gives a sort of greenish zone, which can be a helpful clue.
Okay, we know the culprit, its weapons, it's key.
Hmm.
How does the disease actually unfold inside the pig?
It starts with the pig ingesting the EDC, usually from the environment. Then, using those F18 adhesins, the bacteria latch onto the lining of the distal small intestine, the jejunum and ileum. That's step 1, colonization.
And age is critical here, as you said. How does that play out?
It's all about those F18 receptors. They're not really there in newborn pigs. They start appearing around 10 days, but really ramp up from 3 weeks old.
Okay.
So you have this biological timeline hitting right when weaning stress happens, change diet, environment, loss of sow's milk immunity. It's just a perfect storm of susceptibility.
Once the bacteria have colonized, what's next?
They multiply rapidly and start pumping out large amounts of TX2E toxin right there in the gut. And remember, ED is an enterotoxemia.
Meaning the bacteria stay put, but the toxin travels.
Exactly. The bacteria mostly stay in the intestine, but this TX2E gets absorbed into the bloodstream. There's even evidence it can bind to red blood cells, which might help ferry it around the body.
And this circulating toxin causes the vascular damage. Walk us through that.
Right, this is the core mechanism. The STX2E toxin specifically seeks out GB3 and GB4 receptors, which are found on those endothelial cells lining small arteries and arterioles. By shutting down protein synthesis, the toxin kills these cells. This damages the blood vessel walls, makes them leaky. Vascular permeability increases drastically.
And that's where the edema comes from.
Yes.
Yeah.
Plasma fluid leaks out of the damaged vessels into the surrounding tissues. That creates the gelatinous edema. So infection starts locally in the gut, but the clinical signs and death, that's all down to systemic vascular damage.
Which explains the neurological signs, too. The staggering convulsions.
Directly. It's the same process happening in the blood vessels of the central nervous system. STEC2E damages them, causing swelling around the vessels, perivascular edema, increased pressure inside the skull,
Right.
and necrosis, death of the vessel walls themselves. This can lead to clots, lack of blood flow, ischemia, and eventually irreversible brain damage, focal encephalomalacia. That brain damage is what ultimately kills the pig.
And there's that terrifying lag phase you mentioned.
Yes, the clinically silent but critical lag phase. Studies show it's about 5 days, could be 3 to 9, between finding STEX2E in the feces and seeing any clinical signs.
A ticking clock.
Absolutely. Colonization is happening, toxin is being produced, but the pig looks fine. By the time you see neurological signs, severe, often irreversible vascular damage has already occurred.
Which explains why treatment at that stage is so often futile.
Precisely. The window has closed. It hammers home why prevention, beating that clock, is everything.
So if you encounter this disease, what signs should you actually look for?
Well, in the really sudden peracute cases, the first sign might just be finding a dead pig, especially one of the good ones, the fast growers.
Okay.
If they survive longer, the onset is fast. Severe neurological signs, difficulty walking, stumbling, lying down and paddling their legs, convulsions.
And the edema.
Yes, the subcutaneous edema is characteristic, pathognomonic even. Swelling of the eyelids, the forehead, the jowl area. Sometimes a weird high-pitched squeal if the larynx is swollen.
What about fever?
Crucially, no fever. Temperatures are usually normal, maybe even low. And once signs start, death follows quickly, usually 4 to 36 hours.
And what about the ones that survive the acute phase?
A small number might survive, but end up as chronic cases. They often have persistent neurological issues, a head tilt, maybe circling, some paralysis. They just don't thrive. Become runts, a constant reminder, and an economic loss.
Okay, let's talk necropsy. If a pig dies, what characteristic lesions point towards ED?
The most consistent thing you'll see is like clear gelatinous edema. Look for it in the stomach wall, particularly the greater curvature near the cardia, and also in the mesentery supporting the spiral colon, the mesocolon.
Anywhere else?
You can also find it under the skin, like we said, eyelids, forehead, snout. Also sometimes around the gallbladder or in the larynx.
Any practical tips for doing the necropsy?
Yes, absolutely vital. Do it fast as soon as possible after death. That edema can get reabsorbed pretty quickly, especially in warmer weather, and you could miss it.
Good tip. Anything else?
You might see some clear fluid buildup in the body cavities, abdomen, chest. Lymph nodes might be enlarged and wet, edematous. But remember, in really sudden deaths, the gross lesions might be subtle. You might need histopathology.
Right, the microscopic examination. What are pathologists looking for under the microscope for a definitive diagnosis?
The key finding, the fundamental lesion, is damage to small blood vessels, a degenerative fibrinoid angiopathy or vasculitis. It affects small arteries and arterioles.
Where is it most significant?
Most diagnostically important in the brain, particularly the brainstem, cerebellum, and the meninges, the membranes covering the brain.
And how does that vessel damage translate to brain lesions?
Well, the damaged vessels lead to leakage, so you see areas of edema in brain tissue looks like rarefaction or spongiosis. Plus, lack of blood flow causes nerve cell death, neuronal necrosis, and a reaction from supporting cells, gliosis.
So damaged tissue.
Yes. In severe cases, these damaged areas can liquefy encephalomalacia. Finding these specific vascular changes and the resulting brain damage is definitive proof of edema disease toxemia.
So putting it together for a field diagnosis, what clues does a vet use?
You combine the clues, the epidemiology, 7-14 days post-weaning, maybe a diet change, and crucially, the best pigs getting sick.
Right.
Yeah.
Then the clinical signs, sudden death, neurosigns, that typical eyelid or facial edema, and then the field necropsy. Finding that characteristic edema in the stomach wall or mesocolon, that gives you a strong presumptive diagnosis.
But for absolute confirmation, you need the lab.
Wow.
What's that three-pronged approach?
Yes, for definitive confirmation, it's a trio. 1, bacteriology. You want to find heavy growth of beta-hemolytic E. coli from the lower small intestine.
Okay.
2, genotyping. This is critical. PCR on those E. coli isolates to confirm they have both the STAKES2E gene for the toxin and the FED-A gene for the F18 adhesive. That proves it's pathogenic EDC.
Right. Not just any E. coli.
Exactly. And 3, histopathology. Microscopic check of tissues, especially the brain, looking for that characteristic vasculitis and brain damage. That confirms the toxin did its damage systemically.
And why is hitting all 3 points so important?
Because context matters. Finding EDC without brain lesions, maybe the pig was just a carrier. Finding lesions without the bacteria, maybe antibiotics cleared the bug already. You need all 3 of the bug with the right genes and the specific damage it causes for an undeniable diagnosis.
Makes sense. What other diseases could look like ED? What are the main differentials?
Good question. For neurological signs, you'd think about strep sooties meningitis, but that usually has a high fever and polycerositis inflammation in body cavities. Water deprivation or salt toxicity can cause neurosigns, but the history and maybe checking sodium levels would point you there. There's also a virus, PHEV, but that usually hits younger suckling pigs.
And for sudden death.
You might consider mulberry heart disease. That's a vitamin selenium issue. You'd look for fluid around the heart, hemorrhages on the heart muscle, or maybe clostridial enterotoxemia, but that causes severe gut damage, necrotizing enteritis.
So given all this, treatment sounds pretty tough once signs appear.
It really is. As we said, it's frequently unrewarding, the prognosis is poor. By the time you see neurological signs, the damage is largely done irreversible.
So antibiotics and support don't help much then.
People try parenteral antimicrobials, supportive care, even experimental things like antihistamines, but the efficacy is very limited. That therapeutic window just slams shut too early.
So during an outbreak, the focus isn't really on treating the sick ones.
The focus shifts immediately to metaphylaxis. That means protecting the at-risk pigs that still look healthy. Mass medication of the group, usually through water or feed, with an appropriate antibiotic chosen based on susceptibility tests.
Is that interesting point about which type of antibiotic to use?
Yes, the potential toxin flush issue. Bactericidal antibiotics kill bacteria rapidly, causing them to ling or tores or break open. Theoretically, this could release a large amount of preformed STEX2E toxin all at once, potentially making things worse.
Has this been proven in pigs?
It's a known risk in human STEC infections leading to HUS hemolytic uremic syndrome. While not definitively proven to be a major issue in swine ED, the theoretical risk is there, which often leads vets to favor bacteriostatic antibiotics, ones that inhibit growth rather than killing rapidly.
This really highlights the big shift in thinking, doesn't it? Away from treatment towards prevention.
Absolutely, a fundamental paradigm shift. We're now focused on a multi-layered, proactive prevention model, integrating nutrition, management, vaccination, even genetics.
And regulatory changes push this along too. like the zinc oxide ban.
Definitely. The EU ban on using high pharmacological levels of zinc oxide in feed, which came into effect June 2022, was a major catalyst. ZNO was a cornerstone of prevention for many.
So what are the key prevention strategies now, besides antibiotics? Let's start with management and nutrition.
Management-wise, it's basics but crucial. Strict all-in, all-out flow in barns, rigorous cleaning and disinfection between batches, minimizing weaning stressors, stable temperatures, no drafts, careful commingling.
And nutrition.
Several angles here. Reducing the protein level in starter diets can help limit the fuel for pathogenic bacteria. Increasing dietary fiber is beneficial. Some producers use temporary feed restriction for maybe 24-48 hours right after weaning. Adding organic or inorganic acids to feed or water can help lower gut pH, making it less favorable for EDC.
And you mentioned zinc oxide. It used to be key, but it's gone in the EU. How did that change things?
Zinc oxide at high levels seemed to work, maybe through antimicrobial effects or improving gut integrity. But environmental concerns, zinc accumulation in soil, and worries about antimicrobial resistance led to the ban.
So the post-ZNO era needs a broader approach.
Exactly. It forces a more holistic strategy, combining those nutritional and management tweaks with other tools like feed additives, probiotics, prebiotics, phytogenics, or plant-based compounds, and importantly, vaccination.
Okay, let's talk vaccines. What are the main types available for ED?
There are essentially two main strategies. First, Seta2E toxoid vaccines.
How do they work?
They contain an inactivated form of the Seta2E toxin itself. The pig's immune system sees this inactivated toxin and produces neutralizing antibodies. These antibodies circulate in the blood. If the pig later gets infected and toxin is produced, these antibodies bind to it and neutralize it before it can cause damage.
Any key advantages?
A big one is they protect against the effects of the toxin regardless of which F18 type or even other fimbrial types the EDC strain might have. V purity is a commercial example.
Okay, what's the second type?
The second type is anti-adhesion F18 vaccines.
Targeting the grappling hooks instead of the weapon.
Exactly. These are often live but harmless E. coli strains that have been engineered to express the F18 fimbriae, but they don't have the toxin gene.
And how are they used?
They're usually given orally. They colonize the gut temporarily and stimulate local mucosal immunity, specifically against the F18 adhesin. This prevents the real pathogenic F18 positive EDC from being able to attach in the first place. If they can't attach, they can't produce toxin effectively where it matters. Edema vechi is an example.
So different targets, different mechanisms. One systemic against the toxin, one mucosal against attachment.
Right. Inactivated versus live, toxin target versus adhesin target, systemic versus mucosal immunity, broad toxin protection versus F18 specific attachment prevention. Different approaches.
Now, this leads to what you call the ultimate prophylactic tool, genetic resistance. It sounds like a game changer.
It truly is. We now know that resistance to EDC colonization, at least F18-mediated colonization, is basically controlled by a single gene. It's called FUT1 on pig chromosome 6.
Wow. How does that work genetically?
There's a specific tiny change, a single nucleotide polymorphism, or SNP, in this FUT1 gene. A switch from a G to an A at one position, nucleotide 307.
And that determines resistance.
Completely. Pigs that inherit the A version from both parents, they have the AA genotype, they simply fail to produce a functional F18 receptor on their gut cells.
So the bacteria have nothing to grab onto.
Precisely. They are completely resistant to colonization by any F18 positive EDC.
How's this used practically?
We have DNA tests now. Breeding companies can easily test their pigs, identify the ones with a resistant AA genotype, and use marker-assisted selection to basically eliminate the susceptible G allele from their populations.
Creating herds that are inherently immune.
To F18-mediated edema disease, yes. It's a permanent, built-in solution that doesn't rely on drugs or ongoing vaccinations for that specific pathway. It's a fantastic example of using genetics to solve a health problem sustainably. So, pulling it all together, edema disease is this really complex, fast-moving enterotoxemia. Trying to treat sick animals, mostly futile, that window closes way too early.
Right.
Which has forced this big shift towards prevention, a sophisticated integrated model really pushed forward by things like the zinc oxide ban.
So the best defense now is layering these strategies.
Absolutely. The most effective long-term control programs combine multiple modern tools. You've got the power of genetic resistance, selecting for that FUT1 del A genotype. You layer on robust vaccination, especially those STX2E toxoid vaccines that neutralize the key weapon. Combine that with precise nutritional management, getting protein levels right, maybe using fiber or acids, and underpinning it all, sound husbandry and biosecurity. It's a multi-pronged approach. And really, the future of managing diseases like this sustainably, especially as we try to reduce reliance on antimicrobials, isn't about finding one magic bullet to replace an old one.
It's about building resilience through integration.
Exactly. Embracing this comprehensive, layered approach. That's how the industry can effectively manage costly diseases like edema disease going forward. The ongoing evolution of these strategies is really shaping modern animal agriculture. Makes you think, doesn't it? What other complex diseases could we tackle this way by integrating genetics, immunity, and management so strategically?